Hello and welcome back to Legal Thinking with me, Liam Pape, and I am once again joined by my colleague Edward Wotton. Edward, how are you?
I'm good, thank you, Liam. Thank you. I had a nice break.
Are we allowed to say where you were, or are the court proceedings private and we're not allowed to declare exactly how long your stint with Her Majesty's Finest was?
Yeah, no, the stint was a month off with my newborn child, so yeah.
Oh. I've been greatly misinformed. Anyway, welcome back. We had plenty of listener mail whilst you were away saying how much everyone missed you. I'll be sure to send at least a couple of sacks of that over to you. But I realise that you have other things to deal with.
Looking forward to it. This week, we have on the podcast an informative discussion about myocardial infarction, which, as you can probably tell by the name, is a serious heart condition which can unfortunately be fatal. The impact of the pandemic on the incidence of the condition and treatment too.
On this episode, Ed is joined by Joachim Stanley, a member of our medical negligence team, and consultant cardiologist Dr. Stephen Hoole, who has a specialist interest performing complex coronary intervention, so is well placed to tell us about all things myocardial infarction.
Without further ado, let's roll the tape. Okay, so thanks for joining us, everybody. So today we are talking about the treatment of myocardial infarction. Hopefully I'm pronouncing that correctly, and its relation to coronavirus. So as some people have seen, when coronavirus first became a thing, the relationship between COVID infection and subsequent myocarditis was noted, and sometimes they could develop myocarditis, and basically I guess there's a relation to myocardial infarctions in there somewhere. So I guess the first question would be for you, Stephen, or Dr. Hoole, which would you prefer? So Yeah, Stephen. First question is for you, Stephen. So if you could tell us a bit about myocardial infarctions, how do they present, in who, and what should doctors be looking out for?
Okay, well, thanks very much. You have pronounced it correctly. So myocardial infarction is a medical emergency, and patients present unwell, unsurprisingly. They commonly experience chest discomfort, which they classically describe as a tightening, goes to the jaw, down the arm, but it's associated with things like breathlessness, sweatiness, nausea and vomiting, sometimes palpitations, sometimes dizziness. I have to say it's important to remember that that's the typical presentation, but patients may present atypically, and particularly women and people of ethnic minority may not actually describe the classic symptoms. So clinicians should be alerted to the possible diagnosis in patients that have risk factors. And I want to touch on those because I think that's important. Obviously, as we get older, the risk of myocardial infarction goes up. Male sex is also a risk factor, as is diabetes mellitus, smoker, hypertension, hypercholesterolemia, and family history. But these are all the things that are taught in medical school. But I think what's less well recognized is that inflammatory conditions such as rheumatoid arthritis, for example, can increase your risk of having a myocardial infarction. Atherosclerosis is an inflammatory condition, and any inflammation can cause plaque rupture. So that's how patients present. The signs are quite, patients just look unwell. And I don't think you necessarily need a medical degree to know when someone's having a medical problem like a heart attack. They look pale, they look ashen and grey, they may be struggling, they look unwell. But they can have a number of other signs, high or low heart rate, high or low blood pressure. But those are the classic symptoms and signs.
Okay. So I was going to pass it over to Joachim now, who's a member of our medical negligence team, and I think he had some questions as well.
Yeah, well, I mean, moving on from that logically, we've now got a patient presentation profile to work with. How do you then confirm the diagnosis? What do you look for and what tests are done?
The key diagnostic test, and it's often done by paramedic crews or immediately in the emergency department, is a 12-lead ECG. And we are looking specifically for ST elevation.
Can you take us through what an ECG is?
So it's an electrocardiogram. It's taking an electrical recording of the heart from multiple different leads that are attached to the chest. And by studying those leads, you can diagnose ST elevation, which is a sign that there's a heart artery that's occluded, and it will give you some idea of the territory that may be affected. And that's the key diagnostic test that usually results in, if ST elevation is present, with activation of what we call a primary PCI pathway. That's an emergency transfer to a heart attack centre for emergency invasive coronary angiography.
And I think I'm right in saying that it's important to take a blood test as well initially. Is that right?
You can. Often it takes a bit longer for the blood test to come back. And the blood test you're talking about is troponin. Sometimes, if the diagnosis isn't clear on the ECG, clinicians might wait for a blood test, but it's not necessary for the diagnosis of an ST elevation myocardial infarction. Frequently, we'll have a patient transferred to us who has not had a blood test, but has classic presentation with the ECG changes, and we will accept them and treat them without a blood test.
Okay, so the patient's now in hospital, and we're going to assume that the ST segment of the ECG is abnormal. What sort of treatment is then offered to that patient?
So, patients will have medical therapy to start with, and they might have that in the ambulance en route. And the key thing that we're looking for them to have is dual antiplatelet therapy, loading doses of aspirin, and usually either ticagrelor or prasugrel, although we can sometimes use clopidogrel. So that prepares them, if you like, for what they need, which is often the infarct-related artery being opened with a stent. So they go directly to the cath lab. They have an invasive coronary angiogram, usually done through the wrist artery. We identify the blocked blood vessel in the heart, and then we open it up with balloons and balloon-mounted stents.
And after the stenting's occurred, yes, I presume the aim of this would be to widen the blocked coronary artery, or arteries, plural.
That's right.
Can the patient typically expect to go back to a pretty normal lifestyle, and do they have to watch out for anything after this?
So, opening the artery as quickly as possible is really important to minimise infarct size. And if we are able to do this, it's a time-dependent treatment. So if we're able to do this quickly enough, we can salvage myocardium, and as a result, the heart attack is smaller, and then patients hopefully will have a better recovery with a reduced risk of downstream events. And the downstream events are heart failure or rhythm disturbances. And the vast majority of patients, if we are able to open the infarct-related artery, will make a reasonably good recovery and should hopefully be able to lead a reasonably normal life afterwards.
And myocardium is synonymous with heart muscle, isn't it?
That's right, yeah.
Right. So it's time dependent. So the more swiftly one acts, the greater the chance, I guess from what you're saying, of salvaging as much myocardium as possible, because the damage to it from not having blood flow will be minimised. Patients have a relatively normal lifestyle after that. And do they have to be on the lookout for any symptoms afterwards? Is there anything they need to be aware of?
Well, they're usually started on some medications, to what we call secondary prevention medications, to reduce the risk of it happening again and to help the heart cope with what has been some damage. Okay. So you're touching upon a really important thing, which is that patients go to rehabilitation and they get the support they need to both understand what's happened to them and what changes they need to make to their lifestyle. For example, if they're smoking, if they have an unhealthy lifestyle, what they can do to help themselves. So there is some education around post heart attack care.
Right.
but they tend to be followed up in local cardiology services and then with their primary healthcare physician. So that's the usual management afterwards.
Okay.
But yes, part of that education is what to look out for if they're breathless, if they have more chest pain, if they have palpitations, dizziness, or blackouts. These are all things that we're reviewing at clinic follow-up.
Sure. And Ed touched on the relationship between coronavirus when it first became known and a condition called myocarditis. Myocarditis, as I understand it, and do please correct me if I've misunderstood it, is characterised by swelling in and around the heart. And I suppose it would be helpful to our listeners for you to take us through how the relationship between coronavirus and myocarditis came to be known, and what the research demonstrated or appeared to demonstrate at the time.
Yeah. I think it's useful just to take a step backwards, and we obviously understand quite a bit more about coronavirus than we perhaps did in the first few months of 2020 when it started to present itself. I think what we know is there's a direct toxic effect of coronavirus, COVID-19, on the heart. And that's due to direct viral binding and release from the myocardium. But there's also this indirect inflammatory response, which you've mentioned. I've mentioned about plaque instability and rupture in inflammatory conditions because it is an inflammatory condition. And that's one way that the heart is damaged by coronavirus. And actually, that didn't get so much press as the second thing which you've mentioned, which is the myocardial inflammation or myocarditis. I have to say that I think, the lay media, and also there was a lot of case reports around the time about myocarditis, led to this being almost at the forefront of people's minds when they were faced with a case of patient with chest pain and some ST changes. But actually, in reality, it's still a reasonably rare diagnosis. And subsequently, we've learned that actually true myocarditis probably is still quite rare in the COVID cases.
Right.
The other ways that the COVID can damage the heart, microthrombosis, because they get a disseminated intravascular coagulation. They also can get stress-induced myocardial damage, just simply by the patient being very unwell. Supply and demand is mismatched, and so blood supply can't meet the increased demands of a patient that is systemically very unwell with a high heart rate and high blood pressure. And as a result, they can have an infarct. There are a number of different pathological mechanisms that COVID can affect the heart, whereas myocarditis is only one of those things.
Okay. It was fascinating that you mentioned that myocarditis and underlying vascular issues in the heart, so presumably in most, or for the most part, atherosclerotic disease can act synergistically, if I've understood that correctly. Does that mean that, if you have atherosclerosis there, then the risk of something being set off is higher?
I think what we've noticed from epidemiological studies is that if you have cardiovascular disease already and then you develop COVID, those patients had a worse prognosis. That's maybe because it's a surrogate for patients that who are of older age, have other comorbidity. So usually the sicker COVID patients had quite a lot of comorbidity, and including cardiovascular disease. But the other thing is that if patients developed cardiovascular complications of COVID, again, their prognosis was worse. So I think that's to bear in mind. To my mind, plaque rupture and a common or garden heart attack was still a common scenario in the COVID era, and we shouldn't forget that.
So it follows from what you're saying, I think, that even at the height of coronavirus as a pandemic, it would have been incumbent on treating clinicians to rule out a myocardial infarction in the first instance when they got a patient in with quite worrying chest symptoms. Is that right?
I think that's correct. I mean, the diagnosis of myocarditis, I mean, it has a very similar presentation in many respects to, as I say, a heart attack. It's quite difficult to diagnose clinically. The diagnostic tests that we've mentioned with ECG, for example, may look identical. So you do need to do this. I think you do need to do an invasive or non-invasive coronary angiogram in the vast majority of patients. So, it should be encouraged. It's really, myocarditis in my mind is a diagnosis of exclusion. You should exclude the very important and time-dependent diagnosis of myocardial infarction before you're starting to consider slightly rarer myocarditis.
And the next obvious question is, what happens if you fail to exclude it?
Well, as I said, it's a time-dependent treatment, opening the artery, and patients, if you miss the diagnosis and start treating myocarditis, which is mainly supportive treatment, there really isn't a direct treatment for myocarditis. You miss the opportunity to salvage myocardium that may be caused by a heart attack, and as a result, patients have bigger heart attacks and have worse outcomes. So they have more heart failure, more arrhythmia, and their prognosis is impacted. So it is one of those diagnoses that you should really be, in my view, you should be sure that the patient doesn't have a myocardial infarction before you're thinking about the diagnosis of myocarditis. And the only way to be sure is to really do some form of coronary imaging.
Right. So patients have to be treated as if they may have myocardial infarction at first instance, and then one can come on to consider whether myocarditis is an issue or not. But that also brings us on to the question of how patients actually presented when the pandemic was going on. In your clinical experience, were patients often noticeably sicker when they turned up to a hospital than had previously been the case, or did they present with more issues?
Well, I think there was a reticence for patients to present to hospital, both to avoid them getting COVID, but also to help the NHS. And so we were seeing later presentations. And that obviously in itself resulted in sicker patients arriving. There were clearly pathway delays. Our primary PCI pathway, although it was fully open throughout the pandemic, because we had to use protective equipment, there were delays in delivering that. So the delays, if you like, of delivering heart attack care did result in sicker patients. But we were seeing odd presentations. There was more out of hospital cardiac arrest. The patients were sicker. We were seeing strange things like multiple plaque rupture. Normally a heart attack may just have one culprit. And and I think many others, saw patients with multiple culprit vessels that had ruptured plaque.
Presumably meaning that there's a greater chance of them needing open heart surgery and coronary artery bypass grafting rather than the closed heart repair, I guess.
I think it just speaks to the systemic insult that the patient was experiencing. Those patients didn't necessarily have bypass. Patients with COVID did very poorly with bypass, and so these were all treated percutaneously.
Right.
They didn't tolerate, if you like, the second injury of going onto a heart-lung bypass machine, and those patients did very poorly. So we were not treating patients with bypass, although you could argue that their anatomy was such that they might have benefited, but the reality was that they didn't tolerate going on bypass at all.
Right.
But also because they had lots more multi-organ failure, as I mentioned about this microvascular thrombosis. These patients were really very sick. And really they were, if you like, presenting with a heart attack, but had lots of other problems with other organ systems that resulted in a very high mortality.
Well, that's the next question I was going to ask, actually, which is, so was microvascular thrombosis something which affected other systems in the body?
Well, yeah, I mean, they had multi-organ failure. It was affecting the kidney. They often had kidney failure, the lung, and they had basically an acute respiratory distress syndrome picture. These patients, the very sick ones, the ones that had severe COVID, were very unwell. Yeah.
And you and I have done cases involving treatment which occurred during this period. And I have formulated the impression you've got quite strong views about what did happen and what should have happened. What do you think are the major learning points for clinicians and indeed everybody else coming out of this?
I think we've been learning about COVID, and I think we understand it a lot more 2 or 3 years down the line than we did. I think common things are common, and I think we now recognise that COVID can increase the risk of a common or garden heart attack, and we should be excluding that diagnosis before reaching for a diagnosis of myocarditis, which undoubtedly was associated with COVID. But it was down the decision tree, down the diagnostic decision tree from heart attacks. And I think we shouldn't forget that heart attacks are a major killer, were a major killer before, and remain a major killer afterwards, after COVID. And that really held true throughout the pandemic. And we needed to continue to screen our patients and make those diagnoses, because it's actually something that we could do something about. We can actually treat heart attacks effectively. We have effective treatments for it, but unfortunately some diagnoses were missed.
Yeah, no, I think you touched on a very important point. And if anyone's listening to this and, God forbid, at some point later you develop any sort of chest symptoms, then for goodness sake, pick up the phone and get it looked at fast.
I think it's important to note that, throughout the pandemic, full emergency services were available for patients. And indeed, many organisations like British Cardiovascular Society was publicising the fact that our pathways for heart attack were open, and we fully staffed and ready to accept patients. And should we face this again, that still will hold true. It's the elective work that has perhaps been put on hold during COVID, but the emergency work remained fully available.
And is there still a backlog now?
Unfortunately, there is, particularly for surgery, and that's not just COVID. I mean, there's a number of reasons perhaps for that, but we haven't fully recovered our position from COVID and the backlog of cases that we've got, elective cases, that is. And of course, some of those patients are now presenting acutely. So, yes, we're not quite back on track, but we're working hard to try and get that waiting list down.
Well, on behalf of everyone here and more generally, thank you for everything that you do.
Thanks very much.
Thank you very much, Stephen and Joachim. Thanks very much for your time. Thank you for listening to Legal Thinking, and thank you to our guests for joining us on today's podcast. If you want to find out more about the topic that was discussed today, make sure to have a look in the show notes where we'll have linked everything up.
And you can find all of the back episodes of Legal Thinking in your podcast provider of choice, and you can also subscribe and follow us on there too. And as always, make sure you leave us a 5-star review on a podcast provider of choice, as that helps other people find us. Thank you very much for listening, and we'll see you next time.
Thanks for listening.